Good evening, all. Some months back, I saw a 40 days old child, male child, brought with the history of recurrent projectile vomiting from 10th day of life. And there is no history of weight loss. So, a male infant, recurrent projectile vomiting from 10th day of life. Right now, I am seeing the child on 40th day. So, what is this? Is it a case of congenital pyloric stenosis? Let's see. I am Dr. Sharat Balaji on behalf of your RxTX. Let's go to the case. So, this 40-day-old child with a recurrent projectile vomiting from day 10 of life, it is absolutely non-bilious. Weight well maintained. Surprisingly, weight well maintained. Multiple visits in the past 30 days. And on examination, there is no palpable olive mass. Child was given a trial of anti-reflex therapy, ranitidine and domperidone suspension elsewhere, but the child has not been responding to it. Still, the projectile vomiting continues. So, what is this case actually? When a male infant, along with the non-bilious projectile vomiting, invariably it is a case of congenital pyloric stenosis. But there are so many ifs and buts in this case. So, what is this? What are all the possibilities? Can it be a GR, a simple reflex? No. The mother is saying the child is projecting the vomiting like anything. Typically, she uses the word projectile vomiting. Doctor, whenever my child vomits, it goes and falls over after some distance. It is absolutely projectile. Can GERD will have that kind of projectile vomiting? Unlikely. Unlikely. Can it be malrotation? Bilious vomiting in the infantile period or neonatal period must be malrotation. But here I don't have any bilious vomiting. So, can I go for ultrasound to look for SMA, SMV axis? Let's see. Can it be pyloric stenosis? We all know that pyloric stenosis, a boy, recurrent non-bilious projectile vomiting, usually at 4 weeks of life. But here it started by about 10th day of life. So something is fishy here, and on examination while feeding, I didn't find any visible gastric peristalsis or a palpable olive mass. So, as of now, it is not a case of pyloric stenosis. Can it be metabolic? An organic acidureas presenting with vomiting? Many organic acidureas can mimic this kind of pyloric stenosis. But in organic acidureas, you have encephalopathy, altered sensorium. This boy is absolutely fine in between vomiting. So, no altered sensorium to suggest metabolic cause. Can it be intestinal obstructions like malrotation? No increased bowel sounds in between, the child is absolutely normal. Can it be a CNS cause? AF absolutely fine, head circumference absolutely fine. So it is unlikely be due to CNS clinically. Again, sensorium is normal. Can it be cow milk protein intolerance? Mother is literally don't take cow milk since her early childhood period, and the child is on exclusive breastfeeding right now. So unlikely. Right then. So what is this condition? So invariably ultrasound abdomen was ordered. It suggests the following thing. SMA SMV axis is normal, so not suggestive of malrotation. Pylorus is just 11 millimeter. The length is 11 millimeter. In congenital hypertrophic pyloric stenosis, it is more than 15 millimeter. And the thickness of that sphincter is 1.8 mm. In congenital hypertrophic pyloric stenosis, it should be more than 3 millimeter. So this is not a case of congenital hypertrophic pyloric stenosis. Barium meal was ordered and it did not reveal, neither the X-ray nor the barium swallow is suggestive of hypertrophy of enlarged stomach or a single bubble appearance. We don't have all those things. And there is no narrowing of pyloric channel. So what is this condition? But there is a significant projectile vomiting at least 4 to 5 times a day, but the weight of the child is maintained. Otherwise, the child is normal. Anti-reflex measure failed. The mother is worried despite numerous reassurance. What should I do right now? So this is a case of congenital pyloric spasm. What is the difference between congenital pyloric stenosis and pyloric spasm? Congenital pyloric stenosis is a structural problem. There is a mass in the pylorus, whereas in pyloric spasm, it is purely functional. It fails to dilate periodically. That is pyloric spasm. So, what are all the differences between this congenital pyloric spasm and pyloric stenosis? Usually, pyloric spasm earlier in onset compared to pyloric stenosis. In between feeding or in between that spasm, the child will be absolutely fine, which is against your pyloric stenosis. Weight gain is well maintained. Olive mass is not there. Gastric peristalsis is not there. In barium swallow and ultrasound, they will not suggest any hypertrophic pyloric stenosis. It is transient. It is transient, and majority of them will resolve on its own. So it is functional impairment of dilatation of the pyloric sphincter. So what can be the management when it is bothersome? Can I give reassurance? I have reassured that mother many times, but it is very difficult right now. So what should I do to control that projectile vomiting? The answer is atropine. Whether atropine can be recommended in pyloric stenosis or spasm, the answer is yes. Even Nielsen textbook says that whenever there is a profound electrolytic disturbances in a case of pyloric stenosis, which makes the child unsuitable for Ramstead surgery, you can try this atropine. What is the role of atropine? The role of the atropine is the pyloric muscle relaxant. Can I try this in pyloric spasm? It was discussed well with our pediatric surgeon, and we wanted to give a trial of atropine in this case. Let's see. But the dose of, what is the dose of atropine in pyloric spasm or pyloric stenosis? The normal dosage is 0.01 milligram per kilogram per dose thrice daily. What is the available atropine in our hospital? The available atropine is 1 ml contains 5 milligram. So what should I do? Or it contains 0.002 ml per kg I can give on conversion. 0.002 ml per kg on conversion. So what should I do right now? I need to dilute 1 ml of atropine with 50 ml of normal saline, and from that solution I need to give how much? So when I dilute 1 ml of atropine in 50 ml of normal saline, it comes around 0.1 milligram per ml. In that I need to give 0.1 ml per kg per dose thrice daily, and it was given to the child. Absolutely beautiful response. The child responded very well. There is no projectile vomiting at all. And gradually over a period of 5 to 6 months, atropine was stopped and the child was absolutely fine. Okay. So this is the recommended dosage as per the weight of the child. Make sure the available strength is 1 ml. 5 milligram, you need to dilute 1 ml to 50 ml normal saline to make it 0.1 milligram per ml. From that, you need to give this dosage. Okay, right. So, course dramatic response, child asymptomatic. By about 6 months, the child is absolutely off atropine drops. Now, the child is around 1 year old, celebrated his first birthday. So what is the carry home? Pyloric stenosis is a structural problem, hypertrophy and hyperplasia of pyloric muscle, whereas pyloric spasm is a functional spasm. Drug of choice for both these conditions. For pyloric stenosis, surgery is the treatment of choice, but before surgery, you can try atropine. It is there in the Nielsen. Atropine, as I told you, it can be used in pyloric stenosis as well as in pyloric spasms. But remember, don't forget to get a pediatric surgeon as well as a gastroenterologist opinion before starting atropine. And atropine is mainly used on off-label purpose. Thanks a lot for your patient listening. Bye-bye.